Good afternoon, everyone. My name is Pasit Sengpanich from Buddhachinaraj Hospital, Femoral. So today, I'm proud to present the case discussion about the femoral shaft non-union. So let's start with the case. A 68-year-old male, he has a motorcycle accident for 1 hour, and he had the wound at the left thigh side about 10 centimeters, and he has the deformity at the left thigh. And this is the film. The film shows oblique fracture with minimal comminution at the shaft of the left femur. So this case we diagnose it as a open fracture, Catalo-Anderson type TA, and for this case, the first surgeon go to debridement and he looked the wound. The wound is good, so they decide to the primary fixation with the open reduction with internal fixation due to the with the parade due to the femoral canal was narrow. Yeah, and this is the post-operative film. And then they follow up at 1 month. This is a film at 1 month, and then 2 months. At 2 months. As we can see, the fracture still has no callus. So the surgeon performed the bone graft on the fracture site, and then they still follow up. This is a film at 1 month after bone grafting. And as we can precise, after 3 months after bone grafting, we look at the fracture, still no callus, and then it had a plate pulled out from the bone. For that event, may I ask the panelists about what they recommend that you think for the first treatment, and what are your plans?
May I ask what was the tissue at the fracture site look like when you put the bone graft in?
I'm not sure about the operative note from that operation. That thing is good. It's not has no any derived tissue or the infected tissue from that event.
Any signs of infection that we need to consider before the first operations, like the wound or lab or any like pain?
Yeah, for that event, the laboratory, they didn't send. They think it's a aseptic non-union at that time, so they still go to the bone graft only.
So, for me, the clue if the metal come out of the bone, I usually think first the poor quality of the bone, and the other thing is there any bone pathology from the infections that cannot hold the screw? And if you see the broken implant, I usually think it's because it's unstable, it moves a lot, but it's aseptic. But this case, the screw just come out, and I'm not sure about either the second proximal most. It is a locking screw, but it's not locked when it comes out of the bone. So first, I think biomechanics is not sound, and the biology is in the equations. Yeah, and is there any like a illness or in this patient because the femur is small? Yeah.
No. He didn't have any underlying condition.
Yeah, I would take it out and do a culture, and wait to make sure that there's no infections.
Any comment from Professor Suthorn?
Yeah. when I look at the immediate post-op X-ray, I think this is you have a very long incision all the way up, I don't know whether this is minimally invasive or is maximal invasive, right? Number one. It's always sometimes difficult whether how many screws we will put. In this case, probably the spanning is too much. If you have span, I don't know, a 6-hole, right? So if the spanning is too much, I understand that we want relative stability, right? But if the span is too much, it's not relative stability, it becomes instability. That's maybe in retrospect, when you look at the X-ray, probably you should put more screw, you know, and come closest to the fracture, that maybe, because if you try to find the reason why this is plate is failed, for sure that is not long enough, or the number of screw is not enough to hold the fracture. In this case, I think the length of the plate should be okay, but maybe the number of the screw is not enough, the spanning is too high. And you do also a bone graft, right, when you present, right? You do some bone graft. This is a bone graft.
Yeah.
If I have to do this, I may be right or wrong, I put more screw. I will not just put only bone graft, because if you have instability and you put the bone graft, the graft will be resolved. And in this case, one of the reasons that you have to find is to put maybe just 2 screws more in order, and hopefully if there is no infection, of course that is what we have to find out, it may unite. Now, the problem is the screw is pulled out. What you can do, I'm not sure whether the original hole is still possible to use. If the bone is good, I may still use the same plate, but now I cannot use the lock screw. I probably have to insert the conventional screw, but in a different direction, not perpendicular. Right? If I count, I still have 4 or 5 screw, cortical screw, that I can put it in different angle. You cannot put the lock screw because it's already, you know, a big hole there. And of course, to insert maybe more screw on the distal part, instead of changing everything, I may try that way.
Any suggestion, Dr. JP?
No, I agree with Derek and Prof on the points. I think the important points to consider here is, was infection controlled after the first debridement? Because it was a type 3A open fracture. And I think one of the things you have to consider with the femur is, with a soft tissue injury that big, even if there is soft tissue coverage, there may have been a significant amount of periosteal stripping around that area, which may have affected the healing potential. Also, the points that Professor made about having long enough plate, having balanced fixation across both sides of the fracture, and probably more, you know, are all valid in terms of the initial stability. If you look at it after the first fixation, there is a gap at the fracture site, and that's another thing to consider. Whether that came from that comminuted fragment that lifted off, but now you have a gap on the far cortex, and then you have, you're trying to get it to heal with relative stability. So in terms of approaching this patient now, I would still need, number one, to rule out infection. That would be the primary point. And then afterwards, then you decide how you deal with that non-union. I agree with Prof that probably rather than just a simple bone grafting, we would have wanted to see if there were cultures taken during the first debridement or even afterwards. What about the blood parameters or infection parameters for the patient? And whether or not you can salvage the implant at this point or need to do something else.
Thank you.
Thank you.
You proceed.
Yeah, okay. So thank you for all your comments. So the case that surgeon will restart everything again with a remove all the plate and debride the fracture site and correct the tissue and apply external fixation. The laboratory for the septic non-union was normal and the tissue culture was negative. And after 2 weeks after external fixation, they convert the plate fixation, the external fixation to the plate fixation and put the iliac bone graft. This is the post-operative film. And then they continue follow-up at 1 month, 6 months, 9 months, and 12 months. Unfortunately, we saw the plate was broken and the fracture still not healed. Yeah. So now I will ask our panelists again about what do you think? What is the problem for this event? The stability or the biology, and what are your plans?
Please.
I think for this case, the problem is both biology and stability. When you're considering it, I think, like I said, maybe from the initial injury or the repeated surgeries, you may have devascularized the area of the bone near the fracture. Again, looking at the diaphyseal bone, it's up to you. If you're confident that there's no infection, if you would have wanted to put an intramedullary device, maybe to make it load sharing, or in our case, probably I would have preferred putting or exchanging it with a circular external fixator rather than just putting another plate in the same area.
May I look at the post-op of the second operation? Okay. This is 1 month. And then next 6 months. I think the gap is getting wider. Right? The gap is getting wider. For locking plate, you have to understand that the patient doesn't complain of pain sometimes because the stiffness of the fixation. But if you look at the progress of the fracture, you realize that it won't heal. And normally it will break between 9 to 10 or 11 months. So at this point, I think it's important that you should go in again, put more graft in order to avoid the breakage of the plate. So when you follow up for the locking plate, I think it's important to look at the X-ray because the patient never complained of pain. Right? It's different from the conventional plate because there is some motion, but this is no motion. But you see that no progress of the healing. So if you can put the graft at 6 months, probably you can save this. Now, the point is that because the span is too much, because we are concerned, right? But this is not simple fracture, you may say. It's not simple fracture. That means you can put screw even a bit closer. I still wonder whether the length of the plate is enough because this is a bridging. When I try to count number of hole and the number of plate, I'm not sure. But if you put more screw on the top, probably it increase more stability. It's always the question whether it's stability or biology. But in this case, I think there's both. The stability and biology is not good because start with open fracture, multiple surgery, some dead bone. So probably that you need more graft. Okay, now after 6 months, you see, next 9 months, okay, and then 12 months. Yeah, that is what happened. Okay, what will you do now?
Let me ask Professor Suthorn about bone grafting. So is there any role of using tricortical bone graft from the iliac crest to support at the medial?
Yeah. I think this is also important. When you take the bone graft, then you have to ask yourself, where shall I put it? Right? In this case, what you need is the medial column. So I will take the iliac crest, more or less like a small plate. And I will put on the medial side and even maybe put some screw in order to hold that. Once you have a medial strut, then you don't have to worry about gap in the lateral. But if you have a gap in the lateral as well as there's gap in the medial, the plate keeps bending all the time.
Yeah.
So you need this in order to place on the medial side and you fill the cavity with cancerous bone. I think this is another point when we put in the bone graft, we have to realize what kind of bone graft we're going to shape of the bone graft, where you're going to put. Sometimes you put in the wrong position, then it doesn't help.
Okay. Let's proceed. Thank you for all your comment. If I heard what you said before, I would do done as you suggest. But for this case, we perform the dual plate fixation with the open lateral distal femoral LCP, and we augment with the small LCP at anterior cortex with the same lateral incision. And for the biology, we put the bone graft to improve the biology too. Yeah. And this is a post-operative film at 1 month, 3 months, 6 months, and at the last is 9 months. And this is the clinical of patient. Yeah. That is all. And the take-home message is double plate fixation provide a good stability and stable fixation for femoral shaft non-union when the femoral canal is narrow, and the one incision for the double plate is less invasive than the additional medial open incision. Yeah, thank you.